or trying to help the patient and do so in a way that's going to get them the best relief with the fewest side effects. And if you don't feel that process with your provider, then you really need to keep searching, because when you find that person that can bring those personalized aspects into the clinic for you, you're going to do a lot better.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff. What's up, Learn Skin learners? It's Dr. Raja here without Dr. Hadar for this session, but we're still going to have a really awesome conversation. We're talking to Dr. Jason Hawks. He's a board-certified dermatologist, and he's also on the faculty at the University of California, Davis. He's been a long-time expert within the psoriasis area, and he's on the board of directors for the National Psoriasis Foundation. And we are going to be talking biologics today. So, Jason, welcome to the podcast.
Thanks, Raja. Looking forward for this fun conversation about biologics.
Absolutely. And, you know, biologics have now really taken psoriasis by storm, but there's so many nuances in there with biologics, and there's so many places that we could begin. But I really wanted to get your take on what are some of the nuances that we should be thinking about when it comes to biologics. How do we become much more tuned into how these biologics could and could not be used when there's so many to choose from?
Yeah, it's really like walking into, a liquor store and saying, I want to find a red wine. There's just so many options. And I think that's really been a struggle for clinicians, because we have not only many agents, but many highly effective agents that are really safe. So when patients are really asking questions, we're really having to get into the nuances there. I thought of this early in my career when some of the pharmaceutical companies used to come and ask, like, if you could choose any medication for a patient with psoriasis, what would you choose? And that used to be an interesting question, but we soon realized that it really wasn't practical because our patients were all unique. And we needed to move towards what was the most important to them, because a patient might value speed as opposed to another patient who might value, decreased frequency of injections. Some patients want a medication that's been out longer on the market, where it's more known to the medical community, whereas others want the newest drug that has the highest efficacy. So we really need to back up from this broad question and really practice personalized medicine, which is, what is it that's the most important to our patients? And are there choices in the biologic, armamentarium that we have that would be a better fit for them?
Yeah, there's no question that we have so many choices. I think you hit the nail on the head when you said it's like walking into a liquor store with red wine. Probably that's going to be the best analogy I've ever heard. I'm going to use that over and over again. I'll give you credit, Jason, but that was a good one. I do have a question, though, in that arena. When we look at psoriasis, we know psoriasis is way more than skin deep. And I know I do a lot of work in the gut-skin axis, but even outside of the gut, you're looking at joint disease, you're looking at cardiovascular disease. And now we know that there are comorbidities, or at least there are other conditions in the gut that can coexist with psoriasis. So is there any nuances here that you can talk about, say like inflammatory bowel disease is one example? How do you approach those other comorbid conditions or coexisting conditions when you're selecting a biologic?
Yeah, this is important. And I think of this, we can add another analogy here is that I think of this like the layering of an onion. And we think of psoriasis in the middle with prototypical skin disease. And from there, we can expand. So you can add an extra layer. You have a patient with just skin disease in the middle. The next layer would be skin disease plus psoriatic arthritis. And then you add another layer. Maybe they have a family history of inflammatory bowel disease or multiple sclerosis. And so you can build on that onion. It can be very small or it can be complex. And there's factors that are beyond just the psoriasis. So we can talk about the psoriasis components, which are skin or joints or gut taint or, the hands or the scalp. There's a lot of factors there. But you can move outside to these other conditions, as you mentioned, like the comorbidities, inflammatory bowel disease, heart failure, multiple sclerosis. we have to take into account pregnancy. That's a big layer in the onion. But there are factors even beyond the health side, such as patient preference, as we talked about already. And then even further than that, insurance, because very rarely do we get to walk in and, again, choose whatever we want. We have some constraints. And so, I think it's good to dive into each of the layers. And then as you kind of understand each layer, each time you see a patient, you say, what are the layers that play into the care of this particular patient? Because then you start to tease out some that are more favorable and you start to move away from some. And usually by the end of those conversations in clinic that I have with these patients, I can start with, the 12 or 13 and then get down to, a couple, 2 or 3, and say, all right, so for you, I think with these different layers, here's what I would choose. So we can certainly talk about each of those layers or some of those layers and sort of go through that rationale that goes through my head.
Jason, I love how you're talking about, all of these other factors that can perhaps drive the decision. We have rotating med students and rotating students all the time, and they'll frequently ask me, and I'm curious what your experience is. They'll say, how do you choose the biologic? And it's unfortunate in some regards, but, sometimes we don't have that free reign. It's you choose the biologics that are allowed by the insurance company because they're just way too expensive for people to pay out of pocket. It's not going to happen. That being said, when you're given choices, can you walk us through, say, if there is multiple sclerosis or if there is IBD, what is your thought process on why you might choose one biologic versus another? How do you walk through that?
Yeah, so there are 2 questions that I think you have to think about when you're approaching this. The first thing is there a condition that my patient also has in addition to psoriasis, which would make one of the choices not an ideal choice or even strictly contraindicated? So that's the first level that goes through my head. The second level that goes through my head, the next question is this patient at risk for something else as a result of treatment? I think that's a good example would be pregnancy, right? So I could treat the psoriasis. There isn't a problem for a lot of the treatments for a patient with psoriasis who's not pregnant, but I also don't want to cause a new problem. And so I think when we think about it that way, we can take, congestive heart failure and multiple sclerosis as a good example, and then kind of tease it out that way. So if you're seeing a patient who has psoriasis with either congestive heart failure or multiple sclerosis, then I move away from the TNF inhibitors as a class simply because there's strong data for most of the medications showing at least worsening of heart failure and or multiple sclerosis. So in this case, it's that my patient has a comorbidity that I'm trying to not make worse. And I know that in trying to treat the psoriasis, I could make those other conditions worse. And so in that situation for CHF and multiple sclerosis or other demyelinating diseases, there's good evidence that the TNF inhibitors can cause worsening or have been strongly associated with worsening. So I tend to avoid that class. But for virtually every other group, so the IL-12 and 23 with ustekinumab or Stelara, with the IL-17s and the IL-23s, there's really limited data. But what we have thus far is that there's no clear worsening. So for me, I just skip that class in that conversation with those patients and then start to emphasize benefits or the drawbacks of the remaining drugs.
Jason, in the age of step therapy now, where a lot of us are, I shouldn't say forced, but we are strongly asked to go through a ladder of treatments. What you're saying would be a great way to just bypass an entire class, wouldn't it? I mean, if you have a patient, you have the conversation with the patient that, hey, we're going to move away from this class, but I'm guessing you put this into your note so that when you're saying, hey, I don't want to do this class, I want a prior authorization for the next class, like say an IL-17 or IL-23, you can justify that in the note. Do you find yourself doing a lot of that in these kind of conversations?
Yeah, so this is definitely a really important part of the onion, maybe the outer skin of the onion, where it's like, this is probably the biggest obstacle or failure that I see on behalf of the dermatologists advocating for their patients. I often will get referrals from other dermatologists who know how to use the biologics, but they can't get approval. They send a patient to me, I read through their notes, I send in my note, and I get approved. And part of that is simply because of lack of documentation. So there are some really key points that people, practitioners can put into their medical notes that will certainly help. Really common things: what therapies have they already tried? What were they specifically? And how long the duration of therapy? But I also very clearly document any contraindications, and there's a couple really easy ones. The TNF inhibitor one is a very clear one for cardiovascular disease or heart failure or demyelinating disease. I put that in bold, I underline it. I never get pushback. So the insurance company is not going to push you to try a medication when from your medical judgment is contraindicated based on these other conditions. And I think another good example of clear documentation to help you get approval for a patient is looking at their medications, because if you have an insurance plan that requires you to go through methotrexate or cyclosporin, it's less common, but we're seeing it still. Then if they're on other medications, some very common medications, so simvastatin, lisinopril, some of these medications that your patients are already on, they interact with methotrexate, cyclosporin, and by documenting that, you can note very clearly that these are contraindicated and then move on in the step therapy. So I always document these very clearly when in my judgment, these medication classes are contraindicated. And you have to remember that the person on the other end of that often doesn't have a lot of medical training, and they're just following an algorithm, which is, does the doctor say it's contraindicated or not? And they're going to move on in that. So you can really help your patients by making that very clear in your notes. And I do that on every patient.
Jason, I can't emphasize enough what you just said. We have a person that's hired specifically to just do prior authorizations because we see so much Medi-Cal, and we're able to get IL-17s covered in these exact kind of scenarios because there are situations where we just can't do the TNF inhibitors and we do move them along. Now, you did bring up something that I think is a really interesting area that I'd like to talk a bit more about, which is pregnancy, because the reality of the situation is a lot of women get psoriasis and a lot of them are dealing with psoriasis through pregnancy. And then there's a lot of questions about, is there any risks to the baby, or if something crosses the placenta, how long does it affect the baby, or are there other issues that we need to be aware of? Can you talk about what are some of the challenges around pregnancies and what are some of the concerns that come up with the different classes that are out there?
Yeah, I mean, as you can imagine, this is a very tricky area. The protections around children versus adults is really important, but you go one level higher in terms of seriousness when you talk about a fetus or a baby or a young child. And so, there's, given the protections around this group, pregnant women as a specialized group, but also protecting the baby, these groups are difficult to manage. And that's in large part not because of their disease per se, but because virtually every clinical trial or study that was done in psoriasis excludes this group. So our understanding of what would happen if we treated these patients with biologics, for example, is largely unknown in many cases because there's not going to be a prospective clinical trial to study that. So that's the first problem with treating this group. The second problem is that, again, it's what we were talking about, that second part of the decision-making process, which is that, is there a medication we might choose that would treat the psoriasis but cause a new problem? And in that case, it would be harm to the fetus. And so we're looking at these different biologics as what's safe for mom during pregnancy or during breastfeeding that's not going to affect the baby. And I think there are a couple key concepts to kind of highlight here. One is that obviously a medication that has a broad mechanism of action that affects much of the immune system is much more likely to have a problem than some of these newer medications that we're dealing with that are highly targeted, selective for a particular aspect, strongly tied to psoriasis, and not likely to impact other normal health functions. And so I think that layer is one process. And I think for that reason, the TNF inhibitors as a class in general have been largely avoided because there was some early data to suggest that maybe broad mechanism of action would cause problems like major birth defects or preterm birth, low birth weight compared to placebo. And so for a while, this class was largely avoided. And there was a big advance in the TNF alpha class with the development of certolizumab or Cimzia, which, unlike the traditional structure of the antibody, lacks the Fc portion, which is required to transfer across the placenta. So now you have a medication that you can put into mom that doesn't get filtered across into the fetus and cause harm. And that makes it really the preferred agent, because even though it's broad acting, the amount transferred across to babies minimal, if any. And so from that standpoint, we have one really preferred agent. But the data is coming out now as we're starting to see some of these patients who didn't know they were pregnant or had really severe disease and was their only option, who ended up electing for therapy. And actually, many of them did very well on TNF therapy, but the risk's not needed when you have another TNF agent like Cimzia that you can use in lieu of, etanercept, adalimumab, and infliximab. So I think in general, we have a clear winner from the TNF class. But with regards to the newer agents, which are more targeted, while we don't have a lot of data, there are some that have actually shown that they're safe. So for example, ustekinumab or Stelara actually appears to be a very safe and highly effective alternative to TNF inhibitors. We just don't have the data for the new IL-17 or the IL-23 class, but we suspect that very much like ustekinumab or Stelara, they're going to be highly effective and also safe.
Speaking of the onion and layering the onion on, taking this to the next level, first of all, thank you for pointing out that even though there were concerns, by and large, a lot of these medications remain safe, but they're clearly better choices in some cases where you don't even have to think about it transferring over. But let's layer the onion here. So what if you have a pregnant woman who's also got psoriatic arthritis, or say maybe it's a pregnant woman with psoriasis who's also got IBD? In those two scenarios, how would you approach looking at these classes and thinking through them? Does it change your approach in any way?
Yeah, so kind of like I was saying that, when you get to the end of your layers, however many that are, there's some clear winners. So if you take a patient with psoriasis, plaque psoriasis, who is pregnant with IBD, in my mind, they very quickly go through that maze, and what pops out is ustekinumab or Stelara. Why? Because it's safe in pregnancy, it works well for the skin, and it's also highly effective as treating both because remember, it's got an approval for inflammatory bowel disease. So this would be an excellent agent for that patient because it would treat their psoriasis, it'd be safe in pregnancy, and it'd be highly effective for IBD. So again, once you empower yourself by really understanding the different layers, you can get there very quickly. If you take the other scenario, though, where you have a patient who has skin disease with psoriatic arthritis, then you say, well, what's eliminated? We've eliminated some of the newer IL-23s that don't have approval yet. So you take an IL-23, you've got guselkumab, you've got the two IL-17s with Taltz or Cosentyx, and so you've eliminated some of the newer, but mostly you've got all of your original agents from psoriasis, plaque only, but now you add psoriatic arthritis. We've lost basically 3 agents. We've got most of what we want. But then if you add CHF, heart failure, or multiple sclerosis, the demyelinating diseases, now you have to take that layer out by removing the TNF inhibitors. And then you say, well, what options do we have? Well, again, coming out of that, you still have ustekinumab or Stelara, you still have Cosentyx or Taltz, so secukinumab, ixekizumab, and then you also still have guselkumab or Tremfya, which could be used. Then you say, well, of those, what are really good in psoriatic arthritis? We know Stelara, unfortunately, very effective for the skin, not very good for the joints, but you now have basically the IL-17s and the IL-23s, which we don't have a lot of data in pregnancy, but we know they're very good coverage from, basically the skin and the joint. So those would be good options because, again, the fact that blocking IL-12 and IL-23 with Stelara or ustekinumab was safe, argues very strongly for the IL-23s like guselkumab or Tremfya being very safe. But I will throw one other piece here, which is that if you eliminated the psoriatic arthritis, remember that phototherapy is very safe in pregnancy. So when you really get into a bind, you still have a good option for skin. Again, not going to help for the joints. So I think in the situation here where you have a patient with skin and joint disease and pregnancy and a history of CHF or MS, then I think you're really obligated to move down to the IL-17 or the IL-23 and argue that the benefits for this patient outweigh the risk and have that very open, clear discussion. So there's really that shared decision-making process in the clinic.
What a fantastic discussion there, Jason. I mean, I think this highlights a couple things that I really just want to echo and I really want to put forth here. One is phototherapy, such an awesome option that sometimes gets overlooked. And I think it's clearly a really safe option in pregnancy, but it can be a safe option in other scenarios too, where maybe a biologic might not be the right next choice. But I also want to point something out to all the listeners as well. You know, I'm an Ayurvedic practitioner and we always talk about alternative medicine as being really catering and being unique and really tailoring it to a patient. And sometimes we look at Western medicine as just algorithmic medicine. We just drop a medication. But I think Jason's point, which he just beautifully highlighted, is that there's actually a lot of nuance and there's a lot of tailoring and there's a lot of art to how you use Western medications too. And so, you know, if you're looking at an integrative approach, for example, just realize that that dermatologist that is a master clinician isn't just using an algorithm. They're really tailoring it to that individual scenario and trying to get the individualized approach that's going to be the safest and most efficacious. I mean, wouldn't you say, Jason, sometimes this art gets a little lost, but there's a lot of art in how you practice the pharmaceutical approach to medicine.
Definitely. I mean, and unfortunately, I think when we're honest, this isn't how medicine is always practiced, you know, and there are certainly doctors out there that are practicing cookie cutter medicine, which they use the same biologic because they know it. And they're really practicing the antithesis of personalized medicine. But I think for those that really care, which are the physicians that, you know, patients want to have, or you might be seeking out, you want to find someone that can really take your value set, your specific health situation, circumstances, and then talk you through that process about why you have a better option with X versus Y and move down that process. But I think just like any practitioner, even, you know, looking at holistic medicine, etc., sort of the non-traditional approach, we're trying to do the same thing, which is that we're trying to help the patient and do so in a way that's going to get them the best relief with the fewest side effects or adverse outcomes. And if you don't feel that process with your provider, then you really need to keep searching, because when you find that person that can bring those personalized aspects into the clinic for you, you're going to do a lot better.
Jason, I couldn't have said it better myself. I have to say, every time I do these sessions with you, whether it's at a conference or when we do these podcasts, I can tell that you're a clinician at heart. And, you know, if anybody wants to see Jason as a patient, he's at the University of California, Davis. Just, you know, look him up. Sorry, Jason, hopefully you don't get inundated with a bunch of patients here, but, you know, clearly you take that art of medicine seriously. I have to say, this podcast was a lot of fun to do. Looking forward to more of these in the future.
Thanks for having me.
Thank you for tuning in to today's episode with Dr. Raja and Dr. Hadar. This podcast is brought to you by Learn Skin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs, or subscribe to the podcast today and never miss an episode. Hey, have a great day and stay curious.